First of all, I'm Rerspiratory. So I'm going to do a lung examination.
Better say check. I'm going to check your lungs.
Check your lungs today. So may I have your consent? So my chapel is beside me. Your privacy is well maintained. If you feel any discomfort or pain, please let me know. I'll stop the examination.
Have a look around. Go there. Okay, very nice. So that's all. Now real inspection starts, right? So we will ask you to take out the dress. Is it okay with you? Can you take a deep breath in through your mouth? So can you take again a deep breath through your mouth and so this is a normal vesicular breathing. Inspiration, expiration. Let's say his breathing become this is prolonged expiratory phase. Let's say he become this is restrictive lung disease. So the next is actually we need to ask him, can you make a cough for me? So if there is actually something like a bronchial asthma, some wheezing sound will come up. If there is bronchiectasis, some crackling sound will come up. So these two never forget. So then I finish this. Then I should see as you know that I have to do some deformity. When I see, you know that there are some barrel chest. This barrel chest is very common because of the COPD. So when you do this assessment, you can actually come again to see is there any deformity, and then you need to look for a scar. So I will tell him, let's say exposed. Yeah, sir, can I see or can you sit up for me? So I see all of the areas. Can you raise the hand up? Okay, can you raise the hand up? So I just see this side and this side. See how many times I move just for a scar. Because this is my diagnosis. Understand? Yes. Yeah. Sir. Yeah, the rest. So I finished. By this way, actually, scar, skin changes, swelling, sign of systemic disease, all has been done. So it will be finished before 1 minute, indeed. So now I will go for general examination because we need to see cyanosis, we need to see the finger clubbing, we need to see warm palm or not, we need to see wash or not, and bounding pulse or not. Why? Because warm palm, bounding pulse, confusion, and then this tremor, clapping tremor means that carbon dioxide retention. Understand? Respiratory patient is in respiratory failure already. Okay? So, and then why you see the wash? Because this is to find out the complication, diagnosis, severity, cause, complication, comorbidity. We have to have all this listing. We are trying to find everything. That's what we will do. So, the way I will do is this. Okay. Sir, can I see? So this is the way I see that. See, I see there is a finger clubbing or not. Okay. Then I will check the cyanosis like this. So if there is any problem, I will see. Can you say your tongue, tip of the tongue, like this? So I will try to see. So try to understand the normal control. All of our tongue color, maybe little bit variation is there. So if you don't know the normal, you will never be able to interpret that normal. So I use my hand, although there is a color variation, still it helps to guide. Compare with this normal control is always important. So this is how I see the cyanosis. Okay, then can I see this side, sir? Yeah. So that's how I feel that one because this side she is doing like this. It's not wrong idea. Because this side is more sensitive to understand the temperature difference. So then I go for pulse. So if it is bounding, there is a carbon dioxide retention, which has a type 2 respiratory failure. So you say that it has a type 2 respiratory failure. And look at the patient's cost. So can you do your hand like this? Okay, so this is actually the flapping tremor. So the another one I should see before during cyanosis is this. When I see this and then I can finish this, compare myself. So it is normal because this is a normal guy. If you see that this area is wasted compared to you, this is it. So maybe the best way will be doing this. Cyanosis, clubbing and cyanosis. Then compare this, can I see your hand in this side and this side? Compare with, or other way, this way also faster.
What this is
comparing this watching of small muscles of hand. So if anyone asks, say that maybe some of our lecturer might not be used to doing this way exactly. He will say, why you are doing, Prof, we are doing this due to this reason, because lung cancer is one of the reasons we are looking for watching of small muscle. They will appreciate it. They might have some other way to look at it, understand? So this way you compare. So positive. So now you go to this side, warm palm or not. So then you feel bounding pulse or not. Then ask him to do like this. Finish. So this is the respiratory flap. Is there or not? So this is actually all done about the general examination. Then feel his pulse actually. Again, maybe you can see, or at the same time you can do, and then see his respiratory rate. But don't inform that you are counting respiratory rate. 1, 2, 3, 4, 5. Maybe around 12 is respiratory. So resting respiratory rate should be fine. Eh? Let me do the atrial distract. Can you look up for me? Yeah, look up for me. Look down for me. Can you show me the tip? Yeah, show me the gum. Yes, gum hypertrophy. You need to look at it. Understand? So then you need to do for the lymph node examination. I'll just simply feel, because if there is a problem, I need to be this, because this is enough for you to look at the lymph nodes, because in respiratory system lymph node is important. So then feel in this, this anterior chain, anterior chain, but never palpate too. This posterior chain, just simply feel, and then shrug. This is very important. Can you shrug for me? Yes. Feel the lymph node. So that's all about the general examination. For me, I will ask him to swallow. This is not written in the book. Okay? Can you swallow for me? Can I see his tracheal position? Okay. Travis, can you swallow for me? Is his trachea deviated?
No.
Come here. Is his, because you are not observing. Is his trachea, Travis, swallow. Is his trachea deviated?
No.
No or yes? Look carefully. Is his, So can you do it again? Is his trachea deviated?
Yes.
Okay. So he got pneumothorax or lung collapse?
No.
So what is the reason? Okay, Travis, look that side.
Physiological tracheal damage.
Can you swallow one? Is this trachea deviated?
Yes.
So that's how you make the deviated trachea in the exam hall. Understand? So positioning is very, very important. So he should be very properly positioned. So now you see, can you swallow? Very nicely centered, right? Then you feel. Okay. I'm so sorry to give you so much toxicity today. It will be 3 fingers generally. So you can feel like this. Then you can feel one finger here and then feel both of the fossas. Understand? Both of the fossas. So because if there is a deviation here, this fossa will be filled up. Actually, if it is a, can I open? Then it's better. So sorry to make you embarrassed. Eh? So, sorry. Because otherwise, it's very hard to actually explain what we are trying to say. Can you breathe in and out for me? Can you breathe in and out for me? So, see, here I pull the skin. Travis, you will be able to remember. And I keep my finger free. So, can you breathe in and out? So, I think in the backside also there is actually same. You can ask him to breathe in and out. Actually, another thing is chest movement. Yeah, you want to record? So for me, I will do this. Breathe in and out. So same technique is I will pull the skin and I will actually not keep my skin fixed, finger fixed with. So the thing is, for chest expansion, the one thing try to understand. Any lung pathology, don't say chest movement normal. If you pleural effusion, definitely chest movement restricted. If you cannot see, this is your eye problem. So if the COPD, chest movement restricted. Because any lung pathology, movement will be restricted. Bilateral pathology, bilateral restriction. Unilateral pathology, unilateral restriction. So don't say chest movement normal. So that's the problem, common problem with the medical students. So another thing we need to remember in the lung, where we are watching. So this part is which lobe of lung? Upper lobe, right? Yes. Left lung, upper lobe. Okay. Back of the lung, which lobe you are watching?
Middle.
Lower lobe. Because lung condition is like this, oblique. So anterior portion is oblique. So it's literally upper lobe. This side is actually the lower lobe. And some of the area here is actually this middle lobe of the lung. Understand? So this is the anatomy. Sorry, not percussion, all the physical examination techniques. Okay, so this is the area we are doing the apex. maybe 1, 2 area. This is apex. So then everybody is doing here for what? I really don't know. It's not needed. Understand? This is not needed to do this. So you have to go for intercostal space. This is the place. The second intercostal angle of Lewis. So some of you is here. Very wrong. You have to go to the mid clavicular line. Otherwise, you will never listen the proper sounds. So generally, we do every alternate space. Understand? Because in exam, no time. In real clinical practice, no time. If the pathology is there, we will go to other place. So this side is relatively down compared to this, because this is a heart. It's cardiac dullness. It's nothing wrong with him. This is actually liver dullness. Understand?
Doctor, we have to go now.
Yeah, go. So don't forget about the respiratory system positioning: mid clavicular line, mid axillary line, and posterior scapular line. Yeah, posterior scapular line. Understand? Every alternate space. So when you do the posterior back of the lung percussion, you will ask him to do like this. Why? Because you want to make this area exposed, as maximally exposed. Because more midline you are, it's automatic bronchial. Understand? So it will not give you the proper. So it's a must. Understand? So when you do so you go to the maximum far. So one alternate space. One alternate space. So then when the scapula is out, mid scapular line. Because I cannot see very well now, because over the bone it will become down. Understand? Yes. So when you hold the stethoscope, it should be like this. Okay. So yeah, can you take a deep breath in through your mouth and release? Okay. So there is bit relative difficulties. Yeah. Take a deep breath. Okay. Want to auscultate him. So again, the mid clavicular line, same way. So see, I am either holding like this or holding like this. Make sure that I'm not rubbing here. Because if I grab here, I can listen some crepitations of pleural rub. So that's how many of the medical students tell us that pleural rub is present. How come? Where is your common sense? Pleural rub means the pneumonia, then pleurisy, then the pleural rub. Where is your common sense? No common sense. Okay, so that's how you will do, and then also this side, this up to these few spaces you will do. I'm so sorry to expose, at least 3 space. Understand? Every alternate space you do, and in the back also you go and also do the same. Again, ask him to see. We have to make him several times like that. So it's always good to do the together. When you go to the back, do all this percussion. That sound just together. So here also you need to do the same way. Make sure that you are holding the stethoscope, not making rub. So like this. Breathe in and out. Same way, same place you use the for percussion. Understand? Every alternate space you go. So then again, breathe in and out. Breathe in. So now when I have this space, because I don't see. Here I cannot see. Scapular line, I will go to the midline. When I have the chance. Because for us, definitely here also midline is better. But midline, the bone is disturbing. How will I listen? So I will go to the maximum midline. Clear? So that's all about this. So now the vocal resonance. Vocal resonance is you need to ask him the same direction. You need to ask him, can you say 99 for me?
99.
Don't move. Can you say 99 for me?
99. 99. 99. 99. 99. 99.
So you need to fully listen. You should go beyond the scapula. So this is his scapula. It's here. It's space, intercostal space, not in the bone. Because bone will be, obstruction already.
99, 99, 99, 99.
I cannot assess
Yeah.
properly because I don't see. So every alternative space. When there is a pathology, you have to go up and down. That space you will do continuous. And always compare. But you did it actually. Because you all are good observer now. Because sometimes the student just one time. It's very wrong. You have to compare the other side sound. Because two symmetrical structure, right?